Dearest colleagues, we have produced this film in order to highlight several important precautions which must be taken due to the current situation regarding COVID-19. It is of particular importance to clarify the reusage of protective face masks. Remaining composed and maintaining concentration is also of high importance. An assistant should observe and assist with the donning procedure of personal protection equipment until you are secure in your ability to carry this out independently. The recommendations in this film are based on international guidelines and recommendations. They apply solely to COVID-19. Unpack and lay the protective glasses on a surface within grabbing distance. Carry out a systematic and thorough hand disinfection. Use the elbow to attain 3 squirts of disinfectant and rub this into the hands until dry. Your name, the time and date should be written on a newly utilized mask. The face mask should be used for one entire work shift. Now wear the protective gown and fasten both cords. Put on a pair of non-sterile gloves. Ensure these are pulled over and cover the sleeves of the protective gown. A protective cap can be worn, however this is not obligatory. Now the new and labelled protective mask may be worn. If you have used a mask previously, remove this carefully from the hook, and be careful not to touch the potentially contaminated exterior surface. Next, spread apart the elastic straps and place the mask over the mouth and nose, starting from the chin and then upwards. Pull one elastic strap over the ears and one under the ears. Press the metal nose grip to the shape of your nose so that the mask is tight-fitting. Carry out a leak test by breathing out powerfully. Now put on the protective glasses. Do not touch the inner side of the glasses, pull the frame gently apart, and place the glasses over the ears in an inwards direction. Additionally, you now have the possibility of wearing a protective face visor. Before we end, we have several recommendations. For invasive procedures such as intubation or bronchoscopy, an FFP3 mask should be used instead of an FFP2. Please do not touch cabinets, door handles, respirators, PCs or work surfaces with contaminated hands or gloves. Always remove gloves beforehand and disinfect your hands. When changing gloves, it is also essential to disinfect the hands, allowing time for the disinfectant to dry. Always place reusable materials such as needle holders or clamps in the white boxes in the room. Thank you very much. Dearest colleagues, the aims of early intubation in COVID-19 patients with respiratory failure are both to prevent aerosolization of respiratory tract fluids and avoid intubation under emergency conditions. A low threshold for early intubation of COVID-19 patients should be held, and a modified rapid sequence induction with video laryngoscopic intubation utilized. High-flow or non-invasive ventilation therapy should be avoided and, if not possible, used for the shortest period of time. Fiber optic intubation should also be avoided due to risk of aerosolization. All necessary equipment for intubation is prepared outside of the patient's room. The team should be kept to the minimal number of personnel required to carry out the procedure. Typically, this would consist of one intubating doctor, a doctor with oversight who also manages the cardiovascular system, a nurse or operating department assistant to operate the ventilator, and a second nurse or operating department practitioner to apply the anesthetic agents and supply intubation equipment. Additionally, there should be a runner assigned to wait outside of the room in case additional equipment or materials are needed. An intubation checklist, which is tailor-made by every hospital according to the resources, will now be carried out by the second doctor and will be clearly communicated to the team. The airway trolley is placed outside of the room so that all potential and necessary airway equipment is quickly available. This includes supraglottic airway devices such as laryngeal mask airways and esophageal tracheal double lumen airways. The on-call ENT tracheotomy team should also be contactable and the telephone number known. The connecting ports of the prepared ventilator are tested. An HME filter is connected between the Y-piece and the respiratory mask. The patient is informed over the anesthesia and intubation procedure in order to attain informed consent. Complete vital sign monitoring is to be carried out and the ECG tone switched on. The working environment must be optimized. Ensure enough space is around the bed. The pillow is removed and the patient positioned in a head-up position. The suction system must be fully functional with the suction catheter attached and in reaching distance of the intubating doctor. The patient should have a minimum of 2 intravenous cannulas which are tested prior to intubation.
Stop!
Before beginning the procedure, the team must follow a 10-second for 10-minute principle, where facts, procedural planning, potential complications and team roles are clarified and outstanding questions can be answered. The second doctor also reads and ensures that the recommendations in the airway protection checklist in COVID-19 patients is sufficiently completed. The procedure may begin once everything is clarified. The oxygen supply to the nasal cannula is turned off. The patient's protective mask then removed. The respiratory mask is placed and held directly on the patient's mouth and nose with a C-grip technique. As soon as the mask is airtight, oxygen is provided through the nasal cannula at a flow rate of 3 liters per minute. The ventilator is set to a CPAP mode without pressure support and with a PEEP of 5 and FiO2 of 1. The patient should be pre-oxygenated for a total of 3 to 5 minutes. Meanwhile, the patient's cardiovascular state is monitored and, if required, catecholamine therapy initiated. Now the 5 minutes are over. In the context of a rapid sequence induction, all anesthetic agents are rapidly applied. The purpose is to achieve a rapid and deep state of anesthesia without eliciting a cough reflux or hiccup. There will be a 45-second pause after the application of muscle relaxants. The oxygen supply over the nasal cannula is stopped. However, the nasal cannula is left in place. The ventilator is also paused. The respiratory mask is either hung to the side or placed in a kidney dish next to the patient's head and held by the assistant positioned near the ventilator. Intubation will now be attempted through video laryngoscopy and with an endotracheal tube with a pre-positioned bougie within. It is important to maintain as much distance as possible between the intubating doctor and the patient. After the removal of the bougie, the endotracheal tube cuff must be blocked quickly to prevent aerosolization. The assistant detaches the respiratory mask from the breathing circuit and places this in turn in a kidney dish. A closed suction system is attached to the breathing circuit, and once any leaks are eliminated, ventilation can be continued. The tube position is confirmed through capnography and auscultation. Contamination can be minimized by having a dedicated stethoscope for each patient, which is left by the patient's bed. Now the nasal cannula are cut and removed. The endotracheal tube is then fixed. The first pair of gloves are removed and disposed of. Now a nasogastric tube should be inserted and its position checked and then fixed. Further procedures. Difficult airway algorithms are well established and are also relevant in COVID-19 patients. The airway or emergency trolley is pre-prepared with all potentially necessary equipment and is placed outside of the patient room. An allocated runner is made available to pass any equipment onto the intubating team. Supraglottic airways, such as a laryngeal tube, should be utilized early on in the algorithm. This is because the potential for leakage or aerosolization of respiratory tract droplets is lower than when compared to bag mask ventilation through a normal respiratory mask. If a second intubation attempt is required, then cricothyroid pressure can be applied. If a further attempt is required, then the second doctor from the team may carry this out. Early consideration of the need for additional personnel or technical assistance is important, as donning of personal protection equipment requires significant time. If a surgical airway is necessary, such as an emergency tracheotomy, then ENT colleagues must be informed early on. Extubation. Extubation should be carried out by a team of 2 individuals with full personal protection equipment. The first person stands next to the ventilator. The second loosens the endotracheal tube fixation tape and operates the closed suction system. The patient is ventilated with an FiO2 of 1.0 prior to extubation and with a PEEP of 5. The ventilator is placed on standby immediately prior to extubation. The patient must then be continuously suctioned whilst the endotracheal tube is carefully removed. The breathing system may not at any point be disconnected. A tight-fitting respiratory mask is placed on the patient covering the mouth and nose, and all vital signs, with particular attention to the respiratory function, must be monitored. Thank you.